Hi, you're watching Hindustan Times. I'm ADITI PRASAD. Welcome to the show. India on Monday has dropped convalescent plasma therapy from its list of prescribed treatments for the management of COVID-19 patients. The move has been triggered due to growing evidence that the therapy does not benefit COVID-19 patients in any which way. I'm joined today by Dr. Rommel Tickoo, Head of Internal Medicine at Max Healthcare, to unpack the implications of this move. But before that, a word for our viewers on what exactly is convalescent plasma therapy. Basically, the therapy uses blood plasma from people who have recovered from COVID-19 to help other people recover. Dr. Tickoo, welcome to the show. Explain to us the rationale behind ICMR's change in COVID treatment protocols.
See, when the pandemic started and initially when we started using the convalescent plasma, naturally we didn't know much about the disease and even about convalescent plasma. The studies had just started. There was not enough data and we were desperate to save lives. We were learning about the disease. We were actually learning more about the disease from the experience of other countries. And that's why we've been using it. And there was anecdotal evidence that it does have a role to play in reducing the severity of disease. But it was all anecdotal. We needed more studies about it. And with time, there was enough data coming in which told us that this might not actually be benefiting patients of COVID-19 and might not be reducing mortality at all. And in fact, even the progression from moderate to severe disease, it might not be stopping that. So, but we did keep giving it because there was not enough evidence. But now there is more and more evidence coming in. And recently, the largest trial of convalescent plasma, the recovery trial in UK, the results of which were published in Lancet, has also confirmed that it doesn't work in patients of COVID-19. It doesn't reduce, it has no mortality benefit and doesn't reduce the severity of the disease. So I think keeping that in mind, plus the fact that there have been multiple studies in Spain, China, Holland, Argentina, all these studies have given the same data and conclusion that it doesn't work in patients of COVID-19. But we still were using it because we have to save lives, because we don't have any specific treatment against COVID-19. And the fact that with time we might have some drug with us, but till then we'll have to keep doing something, we'll have to keep saving lives. But now there is some data emerging which says that because of indiscriminate use of plasma, especially in patients who are immunocompromised, might be leading to emergence of these mutant strains. And it might be actually contributing to a mutation of the virus, which is, again, a big problem because we know what the mutant strains can do. And see, this plasma always had its limitations. It has to be given within 1 week. It has to be given to people who have moderate disease. Now, the problem is that it was most of the time we end up giving it when the patient has moderate to severe disease, when he's already in the hospital. See, most of the time, the patients who receive plasma are beyond 7 days. Naturally, because by the time you diagnose it, the disease gets more progressive, you land up in the hospital. Most of the time, it's 7-8 days beyond that time. Plus the fact that you need a high titer donor, somebody who donates a plasma which is in high titer of antibodies. And to get all that, to have that timing where you just within 7 days and moderate disease, getting a high titer plasma, I mean, all this is very, very difficult. You end up giving it to the right people in a very few percentage. And that's why it doesn't probably work. Same goes for remdesivir. Remdesivir has to be given when the virus is replicating, that is initially. And again, in moderate to severe, by the time you have moderate to severe disease, you are beyond the replication phase. You are in the inflammatory phase where you need probably steroids and other drugs. So timing was very important. So timing is an issue with most of these drugs, whether it's remdesivir, whether it's convalescent plasma. The timing has to be right. You have to choose your right patient and give it at the right time. If you don't do it, it doesn't work. And most of the studies have shown that if you give it when you are in moderate to severe disease, probably you won't get it. It has to be given when it's just moderate enough, when you're not in the ICU on BiPAP on high flow oxygen. It has to be given much before that. So, but even the data says now that even when given to the right person at the right time, it might not be benefiting them enough and might not be reducing mortality. The largest trial which we did in India last year, ICMR, in about 39 hospitals across India, also the PRASAD trial also told us that it is not working, it is not benefiting patients. But we were waiting And it's well understood why, because we have to keep using something to save lives till we are very sure of it. And it's a dynamic process. The virus is evolving. And we don't know. We are learning something or the other. Something which we think might be working today, we might get to know later that there's data that it doesn't work. So we have to keep updating. We have to keep upgrading their guidelines. And you can't blame ICMR or the government for that. What they're doing is basically staying ahead of the game and trying to update the guidelines every now and then when they have enough data. And at least they're honest about it that, see, look, this is what we said some time back, but now we have enough data and it's not working. Plus the fact that giving plasma is a very tedious process. The families have to run from pillar to post arranging plasma and getting a donor. It's an expensive process. You have to get them to the hospital. They have to donate, and then you have to see the titer. Most of them are actually not eligible for donation, and then you hunt for some other donor. And at the end of it, you realize that it's not working. Plus the fact that, they're so desperate that something should work for their loved ones. Something should be in hand to take care of them and to save their lives. You can't judge them for that. They're desperate, and it's well understood. They want to save their loved ones. But at the end of the day, it doesn't really help. So putting so much of effort into something which might not be benefiting their family, friends at all. So it does make sense at this point of time when we have more and more data coming in. One, it is not benefiting. Second, it might be leading to mutant strains. Third, it's a tedious process. Putting so much effort into something which really doesn't benefit the patients, it's better to drop it. And that's what they did.
Fair enough. I understand your point of view, Dr. Tickoo, but have the other countries, I mean, are we one of the last countries to drop its use, or what about other countries? Are they still using it? And what about us? I mean, because even now, apparently, the IMA has now said that it can be used in moderate cases after the government dropped it yesterday. Just one day after that, now IMA is saying this. But first, I want you to answer the question about are other countries using it, and then talk about IMA's new.
Other countries might still be using it, but the data from all the countries says there's not even a single study. Even the studies which have been done in US, UK, all over China, all the studies say it doesn't work. Emergency use authorization was given in certain countries, but with time they realized that it's not working. Probably they're also not using it now. We'll have to go into the statistics to see how many of them are using, how many of them are not using. But the data all over the world is that it's probably not working. And there's enough data to support that. There is scientific evidence to say that. And I'm sure it's not increasingly now, it's not being used because it's not benefiting.
Could this have been done earlier? This stopping indiscriminate use, because one of the very important things that letters written by scientists to ICMR and the top functionaries of the COVID-19 task force said the indiscriminate use of the plasma therapy. Obviously, if the doctor is prescribing it to me, I am going to try and run pillar and post to get that plasma therapy for my loved one, and that is what has happened with a large number of patients. But if it actually is not helping, in fact, helping create mutants of the virus, you think that this could have been stopped earlier by the government, this therapy, or is as the disease is evolving, as treatments are evolving, this you think is the right time that this decision has come?
I think it's come at the right time. In hindsight, we can say that it was late, but I think it's an evolving process. And once you get more the recent data and the recent data which was published in Lancet has come lately, and increasing evidence over a period of time. See, it always has to be done at some point, and we'll always say that it was late, but I don't think so. It's come at the right time, and it takes guts to do what they've done, that to say that something that they've authorized in the past is not working, so we'll take it off. I think they are being very honest, transparent about it, and we should applaud them for that. And there's always a debate about whether it was done at the right time or not, but I don't think it was late. And you have to keep updating the guidelines. Now, even with remdesivir, I mean, everyone is using it. Even in US, it's being used. But again, the largest trial, which US did, showed that it reduces the recovery, the stay in the hospital by 2-3 days, and that's all. It doesn't have any benefit on mortality. And maybe in future, we'll again revisit those guidelines and say remdesivir is of no use, we might not be using it. Yeah. So it's an evolving process. I don't think it's too late. I think it's come at the right time, and it just tells us that we are at it. We are updating the guidelines. We're going through data, scientific evidence, I mean, after going through doing due diligence, going through the scientific data, it's been taken a well thought out decision. These decisions are never taken in a hurry. You have to wait, watch, wait for the data to come in, and then take a decision.
All right. What about, one day after this decision was taken by the government, today the Indian Medical Association has come out and said, lent its support to plasma therapy. They basically said that plasma therapy can be used in moderate cases of coronavirus infection. And they've even said that such patients who are given plasma therapy may need less oxygen with use of plasma. How would you take that comment coming in from the IMA?
Well, that's their opinion. They're entitled to their opinion, but the data doesn't support what they're saying. So most of the studies, as I said earlier also, we have enough data on convalescent plasma, which says that it's not benefiting patients of COVID-19. It does not reduce the mortality. It does not reduce the severity. So to say that it's working in certain patients and it reducing the need for oxygen, it's all based on anecdotal evidence. And there is no data. Where is the data which says that it's supporting them? And with these mutant strains, the ones which we're dealing with right now, I don't think the antibodies would be working against them anyway. So giving plasma from somebody who's recovered in the past 3 months back to patients who are now probably having some sort of a mutant strain also infecting them might not be working at all. And anyway, we have evidence to say that it's not working at all in COVID-19 patients. I mean, they're entitled to their opinion, but in my opinion, I don't think it's benefiting patients of COVID-19.
Dr. Tickoo, would you like to take us through your experience of, I'm sure you must have also, or you might know of people who've been given plasma therapy. What is, in your opinion, how has that helped at all in their recovery? Do you know of any patients who recovered with the use of plasma therapy?
See, of course, a lot of people who get plasma do recover, but then they don't get only plasma. So for me to say that they recovered because of plasma might not be the right thing to say, because they also get steroids, which we know are lifesavers in critical COVID patients. So they're anyway on a cocktail of medicines. They're on steroids, they're on anticoagulants, they're on antibiotics to prevent secondary infection, then they are on remdesivir, then they get plasma, then now we are using the other drugs which are off-label, tocilizumab and things like that. And so you don't know which one is working. That's why you do studies. You can't just say off the hat that this seems to be working because this patient recovered. So that's why you do studies. You have randomized controlled trials where you check it in patients whether this has worked, not worked. So the data doesn't say that it works. So, but anecdotal evidence, maybe in certain cases you do feel, but then they receive so many drugs. So how can you say that it was the plasma which helped?
True. I also want to talk to you about the new DRDO drug, which has been jointly developed with Dr. Reddy's Laboratories. Now, that has been granted permission for emergency use in India. How does this drug work? I mean, do you see this as a life-saving drug? Because there's a lot of confusion in people about how this new drug works. There's hope and also a lot of confusion, yes.
Well, at this point, I can't say it's a life-saving drug, but yes, the interim data seems to be promising. Basically, it's a repurposed drug. It's used in cancer patients. It inhibits glycolysis. Basically, all the cells need glucose, and it just deprives them of that. The cells which are infected with the virus finally get killed because they don't get the glucose, and that's how it functions. But there have been theories about it that it might be harming other cells, normal cells also might be damaging other cells, but there's no evidence of that at the moment. But whatever data we have, preliminary data till now, is that it reduces the oxygen need and severity of the disease from moderate to severe. And that's why it's being given emergency use authorization. But having said that, with time, we'll need more data on this drug also, because there's not sufficient data right now. But whatever data we have is good enough to give it emergency use authorization. But I think more studies need to be done on this. We need more data on this. And with time, we might revisit the guidelines again and see whether we need to continue or not to continue. This process has to go on and on. I mean, you can't blame them for giving emergency use authorization and then you say that they are not using enough medicines, because that's how it is right now.
That's how it is. As the disease is evolving, so is the treatment. But emergency use authorization has also been given to other drugs recently by the drug
Yeah.
controller. Can you take us through that and what looks promising to you as a practitioner?
Well, again, there are a couple of drugs which have been given emergency use authorization, and the data seems to be promising against those drugs also. Now, there's interferon alpha 2b, which is again a repurposed drug, which is used against hepatitis C. We've been using it for years now, and which is very effective in hepatitis C patients. And there are studies now which tell us that this seems to be promising in COVID-19 patients in reducing the severity. And many trials show that. But again, we need more data. But till then, we can use it, probably save more lives with it, as long as it doesn't harm. Safety should not be an issue. And that's what the trials have shown. There have been no major safety concerns. And there's another cocktail of antibodies, casirivimab, imdevimab, which are two monoclonal antibodies. Again, now they are used in mild disease, mild to moderate, where especially in patients who are at high risk, diabetes, obesity, heart disease, cancer patients, to prevent progression to moderate to severe disease. And these are injectables. They also have been given emergency use authorization. I think they'll be available soon in the market. And this is the one which was given to President Trump in US when he had COVID. So this also seems to be promising and reduces the progression of the disease. Then there's off-label use of tocilizumab. Now, tocilizumab is something which can be life-saving, and there is data. And even recently, there was one article in Lancet which said that if given at the right time, it can be life-saving. And see, the problem with tocilizumab is that it has to be given to the right patient, because it can reduce your immunity, it can give you secondary infection, so you have to be very sure. Your platelets should be at a certain level, your neutrophil count should be at a certain level, but the timing has to be right. When you've been on steroids and you're desaturating, when the steroids are not working and you've been about 48, 72 hours about to be shifted to the ICU, that's the time when your inflammatory markers are going high, CRPs beyond 50, 75, IL-6 is high, that's the time to give it. And it can be life-saving. And I've seen patients recovering from it. But again, the problem is by the time you debate giving it, not giving it, the family gives consent, doesn't give consent, you don't get it in the market, it's available in the gray market. I mean, all these issues need to be sorted out, because this also can be a life-saving drug, tocilizumab. So we should work on getting it, procuring it, getting it at the right price for patients so that we can use it. It again, if given at the right time, in my opinion, this is also a life-saving drug. But unfortunately, by the time you get it, by the time you give it to the patient, it's too late. And giving it to those patients who are critically ill, are in the ICU, on BiPAP or some kind of ventilatory support, it doesn't work. It has to be given at the right time. The moment you feel it's been 48, 72 hours, the saturations are going down on room air in spite of being on steroids, the inflammatory markers are going up, just give it. And again, it's an off-label use, but it's being used here all over the world. And data seems to be promising. We should try to get it, give it to all the hospitals where there are critical patients being looked after. And I'm sure this will work wonders also.
All right. So tocilizumab, you're saying can be looked at as a life-saving drug for COVID-19, and of course, like remdesivir, when there was a brouhaha about remdesivir, and we had everybody running after remdesivir, it was nowhere to be found, and that's the case with tocilizumab right now, also in the markets. And you're saying that the government needs to make a plan to procure as much supply to the hospitals so that critical patients can be delivered the drugs, so that they are well on their way to recovery. Thank you so much, Dr. Tickoo, for joining us. I think it was a very, short and concise session where you've been able to take us through the non-benefits, why ICMR removed plasma therapy from its COVID protocol. Obviously, the issue was already in public debate with independent health experts sort of questioning the rationale for keeping plasma therapy in the protocol for COVID-19 management. But now that the ICMR has removed it, I think that will be one less thing that patients are running around and getting traumatized for, not the patients, really, the patient's skin, more importantly in this case, who are already dealing with their loved ones being hospitalized. They're also running around finding medicines and plasma donors. So at least that aspect is taken care of with the ICMR removing it from the protocol of COVID-19 management. Thank you so much, Dr. Tickoo, for joining us.
Thank you.
We hope that you'll keep coming back to us and keep giving your very insightful advice to our viewers. Thank you so much for joining us. Thank you, viewers, for watching.
you.